Good evening, everyone. Now, today, this is the 23rd class since we started this academic activities, and this month you all know that we are reading about the GI malignancies. Now, today we are very fortunate to have Professor Reena Engineer from Tata Memorial Hospital. Ma'am is a professor in the Department of Radiation Oncology, and she is the convener of GI Disease Management Group. And we are really thankful that ma'am has agreed to take not only one, but she has agreed to take two consecutive classes on hepatopancreaticobiliary malignancies. Now, today we are going to read about radiotherapeutic treatment for pancreatic and gallbladder cancer. Thank you so much, ma'am, for giving your time. And may I now request you to take over the session and start the class.
Okay, I'm delighted, first of all, to be, and this is my passion, as you all know, GI cancers when I started treating, and now I feel there's so much to be done for GI cancers, and radiation oncologists have actually not done justice to GI cancers, and there is scope of where radiotherapy is concerned, and we can actually improve the outcomes by contributing radiotherapeutic management for these cancers. So anyway, I would start my talk, and today my topic is to see the radiotherapeutic management of pancreatic and gallbladder cancers. I'll be touching a little bit on chemotherapy and not much on surgery, because then it becomes a very vast topic. So I'll start off with the pancreatic cancers. And as we all know, R0 resection is the only curative option for resectable or borderline resectable pancreatic cancers. And even when these patients undergo R0 resection, the 5-year survival rate is very dismal, 15 to 25%. But we also have to be aware that, yes, where are the major sites of disease relapse? So the tumor bed relapses are like, they have done many studies where they have on cadaveric studies post-mortem, where they've seen that tumor bed recurrences range from 50 to 80%. Peritoneal cavity is 23 to 36%, and liver is around 30%. And what dictates this kind of metastasis or recurrence? It's about the tumor stage, the grade, the resection margin status, and these are the best predictors of survival and outcomes after surgery. So traditionally, pancreatic cancer was just divided into two categories: resectable and locally advanced. But then now, in the past maybe 2 decades or 1.5 decade, there's this new entity called borderline resectable, and we as radiation oncologists also have to be very clear about these definitions. So where the role radiotherapy can come in. So on the first image you see, there is no contact of tumor. You can see a clear fat plane in the triphasic CECT of this of the abdomen, and this is clearly resectable. But then when there's abutment of less than 180 degree, especially of the artery, so then it becomes borderline resectable. And when there's encasement of 180 degree, beyond 180 degree, then it becomes unresectable, and these are very low chances of patients anyway undergoing surgery. And resectable cases are easy, they can undergo resection, but borderline cases where the role of radiotherapy I'm going to talk about extensively in this. So again, about this borderline locally advanced, there are 3 definitions in literature: MD Anderson definition, then AHPBA definition, then NCCN definition. They vary in a few aspects, but the major things you have to remember is you have to every radiology reporting of the triphasic CECT should give us information about these 3 arteries: the celiac axis, the common hepatic artery, and the SMA, and the 2 major veins which they should give us the correlation is SMV and portal vein, superior mesenteric vein and the portal vein. These 3 arteries and the 2 veins, the relation of tumor to them decides whether they are in which category of of resectable, borderline, or unresectable. And I'm not going to go in the detail, but yes, again, so if the veins are involved and the arteries are free, if the veins are involved around 180 degree or little more, so then it comes under borderline resectable. But the artery is more than 180 degree, then it becomes unresectable. So I hope you'll go back and, it should be on your fingertips, these definitions. Again, this is a pictorial depiction of, how to measure the angle. It should be at this 90 degree, between 90 degree and 180 degree. And this is Dr. Suprita had drawn this diagram by hand, and this is her slide. Again, these are the pictures, like you can see that that SMA abutment of more than 180 degree. And then this is the right hepatic, common hepatic artery, which is again encased but up to the celiac axis. So this will be borderline. Then encasement of the hepatic artery, if it is completely encased, then it becomes unresectable. And encasement does, but it should not reach up to. So even so we have to see the correlation of hepatic artery, and the relation celiac trunk is also important, because the surgery nowadays they can actually do Appleby procedure, where they can remove a part of the celiac trunk also. So all these definitions in the literature is very important. Again, the venous criteria of superior mesenteric vein and the main portal vein, and their confluence, the splenic vein, splenoportal confluence, all these, how much they're involved, whether they're pinched, whether they're infiltrated, it all, again, it becomes borderline or unresectable. So these are the pictures, and we have to familiarize ourselves. So it's very important to have a triphasic CT scan. Why triphasic? For triphasic means first phase with arterial phase, where you can see the relation of arteries to the tumor. Then second is a venous, portovenous phase, where you see the veins, relation of veins to tumor. And there's one last phase called delayed venous phase, where you can see the architecture of the tumor. So because the tumor is typically hypodense, and the normal pancreatic tissue is hyperintense. So you can, it's very clearly, and this is very helpful while we are contouring for radiotherapeutic management also. So this, you can appreciate that the tumor is always hypodense, and the normal pancreas is hyperintense. You can see in the contrast CCT. Okay, so now coming to the role of adjuvant CRT. So like say 30 years or 20 years back, there was surgery followed by chemoradiotherapy used to be the standard of care in many of the studies, the older studies. These are the studies from the 90s, where they small 43 sick patients and all, where they showed that yes, when it is radiotherapy, chemoradiotherapy is given in the adjuvant setting, there is benefit in the median overall, as well as overall survival of 2 years and 3 years. But and so this is the benefit in the smaller studies. But this was SPAC1 was a study, and now I'm going to discuss in detail, which actually put a nail in the coffin, and the role of CRT stopped, adjuvant CRT stopped after this trial. And this was designed, and this was published in 2004 in NEGM. And what they did was they calculated the sample size. Target sample size was 280, and they simply it was a 2 by 2 factorial design, and 280 patients were divided into these 4. So one was observation alone, one was adjuvant chemo alone, one was adjuvant chemoradiotherapy, and then the 4th arm was adjuvant chemoradiotherapy followed by CT. Now there's been many criticisms of this trial. Basically, it was a flawed design, in the sense that whenever we have these 4 arms, 2 by 2 factorial design, so if we have to compare these two arms, it should be it was not powered enough. So you have to put in a power, so where you can compare, you have to compare observation versus CT. So both arms should have enough number of cases to be compared against each other. So that was a basic flaw. They just divided these 280 patients in the 4 arms. And then second major flaw was this look at the chemo radiation. What kind of chemo radiation? It was 40 gray over 20 fractions. It was split, and 20 gray, 15 days gap, and again 20 gray. And it was APPA and mostly cobalt techniques, which is not used, and it was maybe an old technique, but still. So this was the result, that there was no benefit of chemoradiotherapy where survival was concerned or where the benefit was concerned. So, and in fact, no chemoradiotherapy is trending towards better. So chemoradiotherapy arm did worse. And this was a trial. And subsequently, there have been at least 6 SPAC studies from then on. And then they have removed the chemoradiation arm completely, and they've been testing many more chemotherapy against other chemotherapeutic agents. So like after this trial was published in 2004, the only indication, so again, I've talked. So even the meta-analysis, now meta-analysis also happened. So like if you have the kind of trial, which was a major contributing factor. So again, meta-analysis also did not show benefit of adding CRT in the adjuvant setting. So after 2004, the adjuvant chemoradiation, the role of chemoradiation has been reduced only to the R1 resection, or when the surgeons feel that they have not done enough like intraop features or some intraop features. So then also basically the only indication remains is R1 resection. And many of the American centers continue to practice adjuvant chemoradiotherapy, but in real sense, R1 resection is the only indication. Now to tell you about this R1 resection. So when the R1 resection happens, this is not a surgeon's fault, because I'll go to the next slide. So traditionally, how they used to report the margin, the pathologists would report only these 4 margins: distal margin, pancreatic neck cut margin, CBD margin, and the proximal margin. And now with this new classification which has come, so now they are supposed to report the medial and superior and the inferior margins. So once they start reporting that, so when you see this is duodenum and this is the pancreatic, which so say there is a tumor here, and there is no anatomic barrier between the vessels like SMB surface or SMA surface and the tumor. So naturally, even if the surgeon does a good job, he shaves off this margin, it will always come positive. And so now if so Dr. Buchler and many other studies, including Tata, we went back to our specimens and we started seeing these surfaces also, the anterior, posterior, and the SMV and the SMA surface. So then the rate, R1 resection rate, which was traditionally reported as 25% in the studies, it jumped to 75%. Because of this, if you start reporting these margins also. And this is our, this is from Tata also. So our resection margin rate jumped up to 77%. And we know, and this is Dr. Buchler's curves, data, survival curves. So when we know that there is R1 resection, this is in red, that survival drops down drastically, R1 and R1 plus resection, red and green, and R1 and R1 plus resection. And so R1 resection is, achieving an R1 resection is actually very detrimental for patients. But surgeons are also, their hands are limited. And this is where the role of chemotherapy and radiotherapy can pitch in to improve these margins, and when they start reporting that. And again, when we see in some papers where they have reported about the outcomes of the R1 resection, adjuvant chemoradiation in the true sense, or adjuvant chemotherapy in the true sense cannot compensate for these R1 resections. So this is like, it is a very good tool and to convince our surgeons that then whenever they are doubtful that they are not going to achieve R1 resection, or when the tumor is actually reaching it, there may still be a thin fat plane you can see between the vessels and the pancreatic tumor. But when they are not going to achieve R1 resection, it's better to give neoadjuvant chemotherapy or chemoradiotherapy in such cases. And these are typically the borderline cases, and this is the concept of neoadjuvant, like any other neoadjuvant rationale. So it can avoid, so within these 2 to 3 months or 4 months of neoadjuvant treatment, patients may show up with more metastases, and this is typically they spared of aggressive such a morbid surgery, and they are known to have aggressive tumor biology, so they can be spared of the surgery. And also we can have a downsizing of the tumor. The tumor can the cytotoxic effects of chemotherapy and radiation are much better when given in the neoadjuvant setting than in the adjuvant setting. So I would say in today's age, whenever chemotherapy or chemoradiotherapy has to be given for pancreatic cancer, it is very important to give in the neoadjuvant setting rather than the adjuvant setting. And so now which one is better? There is no randomized trial to say that only neoadjuvant chemotherapy alone is good, or adding radiotherapy is also going to benefit the patients. So now chemotherapy is we have moved away from GEMSIS, and more aggressive chemotherapies is being practiced. So like it is something called modified FOLFIRINOX, where they give 4 to 6 cycles of chemotherapy, and it is a little toxic chemotherapy. It is expensive. So we in India, we usually go by a general condition of patient is most important, whether he'll be able to tolerate this chemotherapy, because these patients are typically little elderly and their reserves are low. So modified FOLFIRINOX is the preferred chemotherapeutic agent of choice. And then if chemotherapy if after 3 cycles of chemotherapy, the addition of radiotherapy is right now being explored. This is the one major trial which everybody needs to know, this alliance trial. So they are randomizing into the arm 1 standard is M-FOLFIRINOX 4 cycles, and they restage. If there is no distant metastasis, they continue with more 4 cycles of M-FOLFIRINOX, restage, and if they are operable, surgery is performed. And in the second arm, that's the experimental arm, after 4 cycles of FOLFIRINOX, if there is no metastasis, then radiotherapy in the form of SBRT is added, 36.6 gray into 5 fractions, and then again they are staged, and then adjuvant chemotherapy may be given. So this is a trial, and the trial is completed, but there have been some problems in the trials. It's not been published. By end of this year, I think we would expect the results of these trials. And the advantage of SBRT I'm going to discuss later, so that instead of those 5 to 6 weeks of chemoradiotherapy, SBRT gives a similar therapeutic advantage, and the biggest advantage is just 1 week, 1.5 week of treatment over 10 days, and then patient can be restaged or continued with chemotherapy. So you don't waste weeks for a treatment that can be done in 10 days. Okay, so what has happened? Page down. Yeah, so assessment of response post CTRT or post chemotherapy. This is a very important parameter. So you might remember that pancreatic tissue is typically very tough. It has a tough stroma matrix, and these pancreatic cancer cells, adeno cells, are just floating in it. So when we give any kind of neoadjuvant treatment, there is no visual or there is hardly any visual reduction in size, and especially where the tumor vessel interface is concerned, there hardly any reduction. So if the surgeons, hello, Can you hear me?
Yes, ma'am, please.
Yeah, yeah. So surgeons typically, they may say that since there has been no response to neoadjuvant treatment, let us continue with chemotherapy alone. We will not. But then you have to remember that even if there is no response radiologically, these patients have to be explored, and surgical exploration has to continue unless there's visible progression or obvious distant metastasis. So this is a very much takeaway point that yes, you have uh, to reassess these patients after the neoadjuvant treatment, and hopefully now surgeons are catching up, and they are getting more and more involved, and they're getting more involved in reading their own CT scans, interpreting and treating these cases. Just to brief up about the techniques, so this is a old 3D CRT plan which we don't practice anymore. So you see that almost whole of duodenum is getting included, part of stomach is getting included. So this radiation can maximum go up to 45 to 50 gray, and these pancreatic adenocarcinomas are relatively radio resistant and chemo resistant. So this, they are not going to budge with this kind of doses. So 3D CRT is actually not practiced in most of the centers, and this is like how we used to treat in the last decade. Like this is a tomotherapy plan. We would escalate the dose to 60, sometimes 64 gray, also to the main GTV, and then 50 gray, so 25 fractions to the surrounding tissue. Now we have like there is dose escalation, and now protons are coming in, and we are hopeful that yes, we will be able to escalate these doses to a whole new level, and they will be better. That is just a wishful thinking. And but now we have moved over to SBRT to most of the cases now. I'd say around 90 to 95% of the cases, we do SBRT with varying doses. And we say, this is our previous publication, that presentation, that with this kind of approach, the locally advanced and borderline resectable cases, now the resection rate is currently 42 to 45% in our NTMH. And this is a typical SBRT plan, and you can spare the duodenum, you draw a PRV over the duodenum, and you can achieve these kind of doses which you could not have achieved with long course chemoradiation. And it is a very effective, and if practiced well, there's hardly any toxicity. And we are coming up with some good data as part of thesis, and in the next 2 months I think we have a good publication on our outcomes of SBRT. And we typically give M-FOLFIRINOX is a standard chemotherapy. If if the GC is not good, and or it is PS2 kinds, then the medical oncologists prefer nab-paclitaxel. And if nab-pacli is also not an option, then third option is GemCis chemotherapy. So typically 4 to 6 cycles of chemotherapy we give, and then SBRT of these doses. Now we have now for borderline, which are large and there's less chances of surgery, I have right now moved over to 46 to 48 gray over 5 fractions. So it is just, once you have good quality assurance, and you can move over to such kind of doses at present, and it is possible to achieve with this new techniques, and true beam, and with breath control, and all these modern techniques. So this is, and our surgeons, this is photo taken by Dr. Shri Khande. So you see after SBRT or after radiotherapy, actually you can see a nice plane, nice edematous plane between pancreas and the vessel. And the surgeons, you can see they're sliding, they can glide their knife through, and the surgery becomes easy. The typical pancreatic tumor becomes nice and tough, and the vessels, they can palpate, and it's very easy. The surgery in fact is easier rather than in the SBRT or radiotherapy naive patients. You can see this is typical response of SBRT. You can see the whitish discoloration of the superior mesenteric vein. So this is this is, and surgeons get more confident, when we start doing. So now where borderline treatments are concerned, now there's better staging of pancreas. So radiologists are working very hard. There's a protocol. There's a way of reporting of triphasic CECT where they give relation of all these 5 vessels in the report. And the medical oncologist, of course, and FOLFIRINOX is a standard of care and is doing very good. Now we have started seeing 20 to 30% of the cases visible regression of the tumor with just FOLFIRINOX. And SBRT, of course, is being evaluated to very high doses now. And surgical oncologists have started doing aggressive arterial and vein resections. But the final say is with pathologists, because they are the ones who is going to see on the specimen actually what happened to the tumor, what will be the prognosis, what is the cut margins, like that. So they are the actual winners who are going to decide and tell us about the prognosis of these cases. Now coming to LAPs, is locally advanced pancreatic cancers. And so I would say that, so this LAP07, we have to remember, all the students should remember only one trial on locally advanced, where this was published in JAMA in 2016. And this was a trial design where they randomized, there were 2 stages of randomization. First stage was they were comparing gemcitabine alone versus gemcitabine plus erlotinib. And then the second randomization was they continue to receive the same chemotherapy or they add chemoradiotherapy. So this radiotherapy, I think it was a typical 50 gray into 25 fractions, long course chemoradiation. But there was a slight benefit in the progression-free survival, local progression-free survival. There was a trend, but there was no benefit in overall survival. So again, the medical oncologists argue that yes, in locally advanced pancreatic cancers, there's no role of radiotherapy after this trial. But as radiation oncologists, we know that yes, the local radiotherapy can delay, especially now when we have started using SBRT in high doses. We are saying that local progression is delayed typically up to 2 to 2.5 years, sometimes 3 years. So there is a role, and we cannot write off the role of radiotherapy in locally advanced pancreatic cancers. And it is important to also know that this FOLFIRINOX chemotherapy is very toxic. Many of the, like 35 to 40% of the time, patients land up in ICU and need a chemo break. The GC goes down. And so that is the time, yes, when they need a chemo break for few months, we can control, or we can at least hold on to the tumor for few more months by giving chemoradiotherapy. And so case selection for these cases becomes very important. And in well-selected cases, now the more and more data is coming up that after, say, 6 to 8 cycles of aggressive FOLFIRI, if we add SBRT, they, like MD Anderson series and other series, they're reporting 15 to 30% of R0 resection. So there could be a visible regression, and these, though they are labeled as locally advanced, unresectable, even there's hope for 15 to at least 20% of these cases where they can undergo surgery. And we know whoever undergoes surgery, they have much better survival than just continuing with the chemotherapy. So on this note, I would just summarize about the pancreatic cancer that triphasic CECT is a must. Then we have to differentiate between resectable, borderline, and locally advanced and metastatic. And resectable, they can upfront go for surgery, though at TMH also started because the outcomes of even resectable are so bad. So that we have started a prospective phase 2 randomized study called NEVIS trial, where in the standard arm, they are undergoing surgery, and the trial arm, they are undergoing neoadjuvant chemotherapy and SBRT, and followed by surgery. So the outcomes, the trial just started, took off this year and the accrual is little slow. Then the borderline, yes, they have to be given chemotherapy. There is no doubt. 4 to 6 cycles of aggressive chemotherapy and addition of radiotherapy, SBRT, or whatever the NDT agrees. And they should all be explored if there is no obvious signs of progression. And locally advanced, you can give more of chemotherapy and local RT to the well-selected cases in locally advanced. So, Dodo, I will say if you can take up questions now, so otherwise I'll go on to the gallbladder cancer.
Sure, ma'am. Sure. So there are two questions in the chat box. The first question was from Dr. A. I don't know the full name. Is a triphasic CT sufficient, or we have to go for a PET CT for deciding resectability?
So PET CT, there is no role of PET CT right now in any thing. Only the role of PET CT is when they undergo surgery and CEA 99 is rising, or even after neoadjuvant treatment, when we do a response assessment, triphasic CCT, we see there is no obvious metastasis, but there's disproportionate rise of CA 99, which is more from the baseline. So only those cases we would advise PET CT. Otherwise, there's no role of PET CT in pancreatic cancer for these kind of cases.
So I think that does essentially mean that PET CT is done to exclude metastasis and or rule out progression of disease during treatment.
Yes. So till now, there is no level 1 evidence or data to say. There are small studies where even we did at TMH, but there's not strong correlation. So even if it is a PET negative, but in pathology specimen, the tumor comes out because these are not very proliferative tumors. So role of PEC is very limited in these cases.
And I think we have very beautifully described the role of triphasic CT in ascertaining the status of veins, arteries, and even in the delayed phase, the nature of the tumor. And I think the residents need to know that the PET CT does not include a triphasic CT. So the vascular anatomy is perhaps not that much well delineated. Ma'am, your comment please on that.
I didn't get the question.
Ma'am, the vascular anatomy and the nature of the tumor, that's better seen with a triphasic CT?
Yes, definitely. So it is like you can appreciate this hypodensity. I have shown you the images. You can see here, this is nicely hypodensity. This pancreatic part is nicely hyperintense. So if done well, you can actually delineate the tumor very well. So getting good images, it is very important, and then after triphasic CCT, you have to insist on in the reconstructed images. So you can appreciate this SMV is narrowed, is pinched, almost pinched, by both sides of the tumor. So it this relation, so it helps in also contouring and as well as a surgeon to plan. So the length of SMV, beyond the tumor matters, for them to have enough stump to have a venous resection and also have for reconstruction purposes. So length of the vessel involved is also important, not only the circumference. So this is only seen in the reconstructed images, and it is more important for the surgeon.
Right, ma'am. The next question was about your experience on using single agent gemcitabine with concurrent radiation.
Okay, so we do use it as a very standard. So whenever we are giving a long course concurrent chemo radiation, which we practice very rarely now because I always find SBRT and hypofractionated treatment much better because see, if they are not going for surgery, then chemotherapy has a more role to play. So I don't want to waste time in giving 2 weeks of chemo radiation if it can be done in 10 to 15 days. So whenever I'm giving long course chemo radiation, yes, gemcitabine and typical 300 to 350 milligram per meter square weekly has to be given. on Mondays or Tuesdays. This is what we follow.
Thank you, ma'am. Dr. Nilesh has a question. Side effects seen after radiation?
So again, side effects will be duodenal toxicity and the toxicity in the antrum. So you see that the tumor is very close in close proximity to the duodenum and the antrum. In these slides, I did not. Yes, I can catch. Wait. So it's, yeah. I think I must have. So it's the pancreatic tumor is typically, like lying in the cup of duodenum. So wait, there was pathology slide. I can show that. Yeah. Yeah. So you see, duodenum is this. So it's like whatever amount of radiation we'll give, there will be some amount of toxicity, and grade 1 and grade 2. But then it depends, how much doses we are giving. So now with this SBRT, even with this routine, radiotherapy doses, it's we always draw a volume. So it is called PRV. So you can give a margin to the duodenum. You can contour the duodenum, and you can give 3 to 5 millimeter margin to the duodenum, and then you can exclude. So when you are you bullion your vessels and your GTV, you can minus from the PRV. So that ensures that none of the higher doses. So typical tolerance of duodenum, we must know it is like 45% to the 45 gray volume. And like we have published a paper, it was Joji's thesis, where we have also related the volume of the duodenum which is involved. So like if you're giving 50 gray, if when we're giving 55 gray to the tumor, the 1 cc of the volume should be of duodenum should be less than 1 cc. And if we are giving between 50 to 55 gray, the duodenal volume coming in this 50 to 55 gray should be less than 4 cc. And so this is way, and we have published this, it is in the clinical oncology journal. You can take that out, and this is how we can restrict our doses. So it's very important to restrict our doses to the duodenum and the antrum, and we can avoid the ulceration. So if these patients are going to live, at least, so the duodenal ulceration is seen around 10 to 11 months, so say around a year of completing radiotherapy. So if these patients are going to stay for more than 1 year, they might see if you have restricted the doses to duodenum. So there's a nice paper by our group and by my student Joji. So you can see about the duodenal when you're contouring and planning.
Thank
That
you,
answers
ma'am.
your question. Yeah.
Yes, ma'am. The next question is, any contraindication for SBRT in locally advanced pancreas cancer?
Yes. So there was one study by Stanford where they showed when there's a frank infiltration of duodenum, endoscopically, where they in the endoscopy they could see a frank infiltration. So there was some 25 or 30% chances of fistula formation between the tumor and the duodenum. So that's why they are the most experienced group. I've never had experience with a duodenal fistula, so I just go by that paper. So whenever there's a frank infiltration, I reduce my doses. So I go for the more fractionated treatment. You can go up like 39 in 13 gray. Or what I do is like I give my treatment over 13 to 15 fraction, and then I can draw SIB, so the gross tumor volume, if there is some space between the duodenum and the tumor, so that you can go up to 45 gray in 15 fractions. And so all depends on the tolerance, so of the the amount of duodenum involved. So here you can give 3 gray per fraction, that is tolerable, and there's chances of fistula are minimal when there is the part which is infiltrating in the duodenum. So that you can, like you have to balance it out between the tumor control versus the toxicity.
Thank you, ma'am. Uh,
Yeah.
Dr. Durba has a question. Any objective criteria on nomogram to predict R1 resection, or how do the surgeons judge about the possibility of having a R1 resection during surgery?
So this R1 resection, actually, it is, I would say, very dicey, and the sensitivity of a good triphasic scan is, that's why it's very important. So if you see now, you don't see any tumor vascular, there's no fat plane. So this is definitely 100% is going to be a R1 resection. There's no way. It is not a surgeon's fault. He will just shave off, from this vessel. But we know that tumor is reaching. But when there is a fat plane seen, then also uh, the possibility of R1 resection in our own series from TMH is 40 to 50%. So actually speaking, there is no way of saying with confidence that this is going to be a R0 resection, because though you may see a fat plane also between the vessel and the tumor, even if you can see a nice black fat plane, but this if the tumor is reaching up to the surface, and if the tumor, it is definitely going to be called a R1 resection. But it is not because surgeons could not do it. Is just there's no anatomical barrier between the tumor and the vessel. So whenever a tumor is reaching the medial surface, I would say there's a high chance of, maybe more than 75% chance of getting R1 resection. And these are the cases where neoadjuvant treatment should be explored.
Uh, Ma'am, I think we should take another two, three questions and then move on to the next topic. There is a next question from Dr. Suranjan. What are the risk of vascular rupture after SBRT when the blood vessel is involved?
Good question. Even I used to think that, and I used to fear. Believe me, when I started doing SBRT, with shaking legs, I used to quietly go in the OT and stand behind Dr. Shrikande and see, if there will be some ballooning, or there will be some thinning of the vessel, and that used to be my morbid fear. But you see, I showed in that this picture, in fact, the vessel also becomes thick, and it is little tough there, and we've never seen a rupture. It becomes better. The surgeons sometimes they have a hard time removing this tumor, because it becomes like stone. It's very gritty. So even the tumor plus the vessel surface. So we've never seen, and I don't think it is reported in literature, that a thinning of the vessel or rupturing of the vessel. In fact, it becomes better. And sometimes it's like surgeons described as if they're cutting a stone. It's like that hard.
Yeah, that is really assuring, ma'am. I think that is a fear
Yeah.
which is there in all of our mind when we treat some
Yeah.
tumor around the
Now
blood vessel.
I must say, now this modern technique, we have at TMH, we are treating with True Beam, but now this MR guided Linacs have come, and I saw a demo, and I met Dr. Patel Parik, who's doing MR guided SBRT, and he is giving 10 gray per fraction, 50 grain,
Wow.
5 fraction. They publish also. So definitely we have to go on full on, like 10 gray per fraction also is not going to damage these vessels.
And ma'am, do you think a good GI surgical backup is required before doing this type of treatment
Yes,
protocols in the
that
department?
is the most important. That is the most important thing, and you have to have a MDT first with a good radiologist. Don't have a good radiologist, good triphase, a good quality CECT. You've lost the battle, like that, because that's the whole thing you're relying on. So you have to
Exactly, ma'am.
a good radiologist who understands, who reports all these 5 vessels, who sits with you in the MDT, who guides you and the surgeon, like that yes, this was a relation, now this is the relation to the tumor, to the vessels. So every step, radiologist is, I would say, the first most important person. Then, of course, a good medical oncologist, because this amphiphilosis is not a joke. Almost half of the patients, they will require some kind of support and admission and all that. Then, of course, a good radiologist with the best of the machine, where you can practice this breath hold and SBRT kind of treatment. Then, of course, a good surgeon who can do, this, who's hardy and who can, like, willing to take up these challenges. And it's not easy, because they have to, ultimately they land up with all the blame. If anything goes wrong, surgeon is gets the blame. So surgeon has to be, like, very smart and very, like, tactful in dealing with such cases with good surgical skills, because then post-op complications and all. But believe me, post-op complications are also inferior. Did I show you that slide? Where I've seen that there is, we have not published that there is. No, I think I've removed that slide. So post-op complications are typically lesser when we give neoadjuvant treatment, where pancreatic leaks are concerned. See, it's so you see the cut surface. This is the pancreatic duct, which they have removed. This thing is pointing, so it becomes nice and fibrosed, and it is easy to re-anastomose, the pancreatic duct to the jejunum. And it is
Okay.
but if you have not given any neoadjuvant treatment, peak rates are higher, and it is published. So we, as radiation oncologists, we should know of this literature, and we should convince our surgeon that yes, your leak rate is going to reduce, not increase, after neoadjuvant treatment.
Exactly, ma'am. I think it's time that we actually explore this more and do that.
Yeah,
Ma'am,
yeah.
one or two questions. One question is, any difference in dose of SBRT depending on location of tumor, head versus body versus tail?
So no, so this thing is how safely and as much possible you can reduce, you can deliver radiotherapy. So now, typically body and tail are a little more aggressive, because there's again no anatomic boundary. They are just open in the peritoneum. So, like, they have this metastasis, they higher this metastasis. But there, I would not restrict my doses. My the restriction of my doses, or doses, will always depend on the OARs. So you have to, this is not a contouring class, but yes, we do very diligently the antrum, the duodenum, me stomach, duodenum, and the small intestine, all coming in the vicinity. And then we boolean all these three and generate a 3 millimeter or 5 millimeter margin to this, and then reduce, or minus it from our or from our PTVs. So we have to give differential doses, and then we have to, even the physicist, the role of a physicist is very important, and we have to achieve these kind of doses depending on the OARs, the doses with the OARs. And we have a standard pamphlet, and we did our SBA course last year in pancreas, where we have given a handouts, and there exactly they are mentioned, how the OARs, what volume to which dose. So you can basically, it's like you have to give maximum dose to the tumor and minimum dose to the organs at rest. That's how we decide the dose.
Ma'am, any kind of fasting protocol you follow during SBRT, and how often do you need adaptive planning due to change in bowel
That's a
filling?
whole topic. That's a whole topic, and that's a huge, SOP. I won't be able to do justice in that. Maybe we can, if people are interested, we can have SBRT
Yes,
class.
ma'am. I think ma'am, we have to plan one session only on SBRT pancreas.
We have a 3-page SOP for these
Yes,
patients.
ma'am. Ma'am,
Only because it.
Dr. Shogun has a question. Any comment on pre-panc trial by Dutch group?
So Preopanc trial, it is very, it's very strange that it was discussed and it was presented in ASCO in 2018, and there has been no update. In fact, I wrote also, so there's been no response. So it was like, it was a promising, it was one of the trials showed that fit. So they gave, I think, 39 in 13 or 39 in 10 fractions, of 15 fractions of SBRT. So at 3.2 gray, it's not a definition of SBRT, but a hypofractionated RT with gemcitabine, and they showed a better disease-free survival. But unfortunately, those are the only slides what we have on the net. We don't have a full paper, so that's why I did not discuss these slides.
And the last question from this section, ma'am, do you consider bulky parodic node treatable
Bulky
or metastatic?
nodes, yeah, it's M1, and I think chemotherapy. So sometimes we just give 8 to 10 cycles of chemotherapy, and if they are persistent, then we include them in the lower doses, of 36 or 35 grain 5 fractions we can. But generally, by definition, metastatic. About the peripancreatic nodes also, I try to include. So in SBRT, you are not supposed to include nodes, but I do tend to include them either in 25 or 30 gray volume.
Mm.
So you don't want them to increase, while you are doing treatment. So
And
it
ma'am,
is like.
what is your dose fractionation for a clinical T3N1 lesion?
So it will all depend on how its proximity to the duodenum and the antrum or the stomach. So it will. I typically, if it is borderline, I go up to 42 to 45 gray over 5 fractions. And if it's locally advanced, and it is so see, locally advanced also can be early locally advanced, and there can be a new term, never ever, which we'll never send back to the surgeons to be assessed, because if the celiac trunk is encased to the aorta, a superior mesenteric artery is totally encased up to the aorta, these are called never ever tumors. And if they are more central and a little away from the duodenum, I have started giving 10 gray per fraction to these tumors, so 50
Okay,
gray.
ma'am. Okay. And ma'am, is there a subgroup in these unresectable or borderline resectable pancreatic tumors where you would prefer to go with a conventional dose fractionation and definitive chemoradiation?
I've stopped actually. I don't remember giving last 2 years any conventional fractionation. If there's frank infiltration of the tumor? So what I do is, I do a draw SIB, and the part of the tumor which is infiltrating the duodenum, that I give 3 gray per fraction to 10 fractions or 12 fractions, 13 fractions, like that. And the part which is encasing the vessels, and if little away from the duodenum, that part, because they may be borderline also. Borderline tumors can also infiltrate the duodenum.
Yes, ma'am.
So that encasing part. See, so our role of a radiation oncologist, if they are borderline and infiltrating the duodenum, is to sterilize that part of the tumor which is encasing the vessel. Because duodenum is only for the pathologist tray if going to be resected. So I'm not very much bothered, what doses are going into that, because 3 gray per fraction should be good enough to control them. But I'm more bothered about the tumor vessel interface. That should get a good dose, as high as possible.
Right,
So,
ma'am.
my desirable BED is more than 82 gray, the BED of 82 gray or more, if can be achieved. So that will actually sterilize that margin, and surgeon can remove the duodenum part. So it will be a
Right,
win.
ma'am.
Yeah.
I think, ma'am, we are done with the questions in this session, and now we are left with the next one.
Okay. It's almost 9 o'clock. Oh my goodness.
Yes, ma'am.
Yeah.
Actually, I gave you a huge task.
Huh?
Actually, I gave you a humongous task to complete topic in one day.
Yeah,
That's a
yeah,
huge
yeah.
task.
No, my passion is GI cancers, and
I
all
know,
I
ma'am.
might desire is to equip the radiation oncologist. So what has happened even in our books, and even the radiation oncology community, people have not done justice to the GI cancers, and there's a huge potential. And I want to teach this young radiation oncologists, don't give up on these tumors, and there is a huge role, and we have to explore it, and we have to, and with this modern radiotherapy machine, actually the sky is the limit. You can give anything, designer radiotherapy, like that I would call it. and
That's
and and
actually
you
true,
can,
ma'am.
yeah, and very good results you can get, even in the palliative setting, even in the recurring setting. You won't believe our patients live on an average 2.5 to 3 years in a locally recurring pancreatic cancer. So there is no limit of in practicing good radiotherapy with these modern techniques. Okay, so now
Right.
gallbladder cancer. So again, first, I would cover the adjuvant approaches and the neoadjuvant approaches for gallbladder, where radiotherapy is concerned, and little bit on chemotherapy. So, as we all know, again, upper hepatobiliary tumor surgery is the standard of care, and post-op RT has been traditionally given mostly in American settings, and there have been many other studies, even published retrospective. So most of the studies were retrospective, which were published, and they showed that giving adjuvant chemoradiation to these groups. Uh, so adjuvant chemoradiation was mostly given where there was a higher chance, or R1 resection, or the tumors were bulky, or and the surgeons go in and they find it locally advanced. But we see that in this study where they compared, this is a recent study 2015, where they compared the upfront resectable versus surgery with followed by chemoradiation. The survival actually becomes like a rectable when you give adjuvant chemoradiation. And this was the SEER data published in 2008. And they had a multivariate regression analysis, and they tried to study which were the factors which had a good predictors of overall survival. So the age, the female sex, the papillary histology stage, and adjuvant RT. So patient who had adjuvant RT had survival uh, of 33% versus 17%. And therefore, there is some indication, it is a large database, that yes, adjuvant chemoradiotherapy works. And this, again, the article published in 2014 by the Korean group, again, they showed that a loco-regional control is far superior when we give chemoradiation in the adjuvant setting. But overall, NDS-free survival may be the same. Okay, and then surgery alone versus chemoradiation. Again, it is useful. It is like, I'm not going into the details. You can all go in and study these studies. So now, this was again it is a BILCAP study, is from Royal Marsden and from UK. This is a large multicentric phase 3 study, where now UK, they in GIs typically they don't like believe in more of radiotherapy, I think. So they just compared observation alone. So surgery, no adjuvant chemotherapy versus chemotherapy. And chemotherapy was in the form of tablet capecitabine of 6 cycles. And they showed there was an improvement in overall survival when chemotherapy was given. And again, there was another study that even chemotherapy in the form of GEMSIS, when it is given compared to surgery alone, again, it benefits in the survival. So there is evidence now, and because it's mainly because of the medical oncology community, that they had a large trial and compared to surgery. So probably they did not believe the role of radiation. So in both these landmark studies, there have not been a radiation arm. I wish there was, so they would have more clarity. But again, it remains unanswered, the role of radiation compared to chemotherapy for these tumors. So again, there was a systematic review and meta-analysis, and there is clear benefit of adjuvant therapy. But then again, there is no clarity whether this adjuvant therapy should be chemotherapy alone or chemoradiation. SWOG was the only study. It was a phase 2 study, single arm of 79 patients, where they gallbladder cancers was 32%, and there were extrahepatic cholangiocarcinoma were also included, and they gave gem cape, gem cape for 4 cycles followed by CTR, and they showed that the median survival is very decent. In this 2-year survival was 65%, which is very good for a gallbladder cancer. And so there is some indication that yes, chemoradiation in the adjuvant setting is a must. And in this study, the patient who received in the gallbladder cancers who received chemoradiation, let's look at the local recurrence rate was like 0 and 8%. Plus distance, so and compared to distance, so obviously most of the patient had distant metastasis, and local recurrence was very much less. So we know that local recurrence also, though we keep on saying that gallbladder is a metastatic disease, it is not true in the sense that a local control plays a very important role in the management of gallbladder cancers, because even if they metastasize, if they have a local recurrence, they come back, keep on coming back with jaundice. You have to change stent after stent. Each metallic stent is at least 45 to 50,000 rupees. They don't tolerate chemotherapy, palliative chemotherapy. So we should not undermine the role of radiotherapy in these cases. And this is the recent ESMO guidelines, where early stage they recommend surgery followed by adjuvant chemo and chemoradiotherapy, then followed by more chemotherapy. And for loco-regional treatments, they advise the systemic chemotherapy for locally advanced and metastatic cancers. So even in the NCCN guideline, if they are early tumors and they undergo R0 resection, chemotherapy alone should be good enough. Again, there's no clarity, but yes, if there's a R1 resection, R2 resection, or positive nodes, then chemoradiation is one of the options. But again, there is no clarity that where exactly the radiotherapy should be added. And but we know that any T2 plus GB cancers undergoing R0 resection, adjuvant treatment is a must. Adjuvant chemotherapy, now it is a proven role, but the adjuvant role of chemoradiation versus chemotherapy is not proven. So this is the trial by TMH now. This is a phase 2 randomized trial. It is called JCOR. Dr. Anant Ramaswamy and Dr. Vikas Oswal are the PI in this, and they are randomizing the chemo alone, GemCis, and in arm B, this capecitabine 2 to 4 cycles, followed by CTRT of 45 to 50 gray and 2 more cycles of cape. So this is a design, and this 90 patients are to be accrued, and I think we have finished 50 patients on this. Almost half the trial is over, and this will throw more light on the role of CTRT in the operable patients who undergo R0 resection. Now coming to the neoadjuvant treatments. So there was a publication. So whenever there is locally advanced or unresectable cancer, the easiest tendency of the people all across the country and the globe is to give chemotherapy and then reassess. So this was a retrospective study of 37 patients. Yes, some patients could undergo surgery. Median overall survival was 18 months, and progression-free survival was 8 months. And this was my first paper on the role of neoadjuvant. So I did only 3 patients. 3 patients we reported because our first patient was, I think, actually Dr. Tabassum's cousin, and then this was a learning experience for us. So this was a tumor like on the PET CT. We did PET CT because we thought these are mostly metastatic. They will be metastatic, and to rule out metastatic lesions, we did direct chemoradiation. We did not even give chemotherapy for these patients. And then this was the response. This was our first patient, and it was a near complete or complete response on PET CT. And the surgeons, when they operated, it was a PET CR, But this patient, I think she had lots of surgical complications and she died eventually 6 months later. This was our second patient, again a huge tumor on and the gallbladder, and then again chemo radiation. It was complete response. So that gave us an indication that yes, chemo, and in fact chemo radiation, this gallbladder cancer is actually a radio and chemosensitive disease, unlike what our books tells us that it is a chemo or a radio resistant disease. No, it is very much sensitive. And this was the publication, and we were so excited about these first three patients only. And look at the responses, so then I launched a proper phase 2 study. And that time actually we did not have it well defined goals on whom to call locally advanced unresectable, which we do have now. But that time we just did PET CT to rule out mets. And then so we saw that almost 45%, 48% patients underwent surgery of these. They were unresectable. They were declared unresectable by by the surgeons. And out of these, 35% they had 5-year survival, or almost 40% had 5-year survival, which we had never seen or heard for gallbladder cancers. So this was means the proper paper, and on the basis of this paper, this was our doses. Typically we would give, I would say, 57, 55 gray over 25 fractions, and outside to the C we would give 45, 50 gray. That time we did not have a very strict criteria about the duodenal doses, which we have now. So, but this was our initial publication, and till today, 9 patients are still alive of these 28, which is very, very, very encouraging for us. But the downside of this study was there were very high biliary leak, because we did not control our doses to the high limb. And now we know that very high doses causes these vessels to rupture here, and it can cause a bilioma and all those, and then these patients undergo surgery. So almost there were the biliary leak rate was, I think, 45% in this study, which is very serious. And but at the same time, the patients were living. The patients who could undergo surgery and who could withstand all these complications, they were living. So it was, a balance, creating a balance between the toxicity and the survival. And so there was another systematic review by Dr. Krish Menon, and he has included our study. He said this was one of the very good, rest all were retrospective studies. So this was only prospective study showing some benefit of neoadjuvant chemotherapy or chemoradiotherapy in gallbladder cancer. And another study was prospective by Eric Stibala. This is another study in 2004. So now, currently, we are randomizing these patients in the neoadjuvant setting between the neoadjuvant chemotherapy of GEMSIS followed by for surgery versus chemoradiation and chemotherapy followed by surgery. And our endpoint is overall survival, and it's called GBC. And I've not included the slide in this, but yes, that study is ongoing, and we have accrued. The accrual is slow, and we have a little more than a third of patients, more than 30% of the patients. And also we have analyzed, and I could not put up the recent slide, that many of the times we find these locally advanced unresectable cancers, and they've received 6 cycles of, say, 6 to 8 cycles of GEMSIS, and they're still locally advanced, unresectable. They have neither metastasized. So what to do with these kind of cases? Should we add in the chemoradiation? Will there be any benefit? So we did a comparative analysis by Dr. Shwetab, and it is under publication, the manuscript. So of these 34 patients who received CTRT and their outcomes, this is not an updated slide, but their outcomes were far superior when we added chemoradiation to these patients who were limited metastasis or upper parietic nodes, who have not metastasized after 6 to 8 cycles of chemotherapy, and the progression free survival, so they're typically living the median overall survival is coming up to 20 months, which is very in spite of not undergoing surgery. So you see that, if even if these tumors don't these patients don't undergo surgery, and if they don't metastasize and they remain locally advanced, and you've given them very good chemotherapy followed by chemoradiation, there is them there they can live up to 2.5 years, which is very good for where gallbladder survival is concerned. And okay, I have put this slide of Polka GB, where locally advanced we are randomizing between the chemoradiation versus chemotherapy alone in the neoadjuvant setting. And this is like updated. I think we have accrued more than 100 patients now, and this trial is open for recruitment, and I think other centers are also will be participating in this trial, and hopefully we'll finish it. So this is my take on gallbladder cancers. So Dodul, we can have an open discussion, and people can unmute or whatever. I'm open to answering questions.
Thank you so much, ma'am.
Yeah.
Hi, so everyone, I think please unmute yourself, and ma'am, once that you interact with her, it will be really an opportunity for you to ask your questions and get all your questions and confusions cleared from ma'am.
Hello.
Hello. Yes. How Doodle? How do I see? Because I stopped my end show.
You have to end your presentation.
Okay. How do I do that?
And you can close your presentation, ma'am.
Okay. Wait. I'm trying to wait. I'll just so I don't have to. If I minimize, that won't be okay. No.
Yes, ma'am.
Stop.
I'm stopping the share screen option. Yes, ma'am. It's okay.
Yeah. Tell me.
Hello, ma'am.
Yeah.
May I request you all
Yes,
that before asking question, you please introduce yourself?
Yeah, you can show your faces as well.
Ma'am, myself,
Yes, ma'am.
Dr. Yes, ma'am. Myself, Dr. Avinash from KGM. I need to ask you a question regarding should a patient with deranged lefty with having PTBD or ERCP done can be considered for a candidate for NACTRT?
So this you're talking for gallbladder or pancreas?
No, ma'am. Gallbladder only.
Yeah, so gallbladder we have to give typically fractionated RT, and then concurrent chemotherapy will not be given if the bilirubin doesn't drop down to below 3. So we'll have to wait. So after ERCP, actually, if it's a good stenting done, then around 15 days it takes, for the for the bilirubin to normalize or drop down below 3. So this the medical oncologists have to be comfortable giving a concurrent chemotherapy, because I don't think RT alone will be like a palliation only. So if you want to give them a real benefit, we have to wait for the bilirubin to drop. Does that answer you?
Yes, ma'am. Ma'am, is a dose of 45 gray if we plan a 3D CRT plan in NSCTRT plan. So is that okay if we plan a 45 gray to downstage the disease and go for surgery with concurrent chemotherapy, gemcitabine single agent?
Yes. So instead of giving only 45 gray, I practice. And so if you have a provision of IMRT, you can give a SIB. The boost, that is always better. You can give up to 50, 52 gray. But I would say even 45 gray is a very good dose. Don't worry. 45 gray can be given. or you can give, to the tumor volume, you can give some margins. And this gallbladder, mind you, is a very mobile, is a moving tumor. So ideally, you should do a fluoroscopy, or if you have a 4D CT in your institute, you have to see the movement, superior inferior movement, and rather than giving a, like a general margin of say 8 millimeter or 1 centimeter, you have to give individualized margin depending on the motion, because some patients, they breathe heavy, and their superior margin motion can go up to 2.5 centimeter, whereas some patients are very, okay, 5 millimeter or 8 millimeter. It should be individualized so you can reduce the toxicity.
Okay, ma'am. Thank you, ma'am. Thank you very much.
Okay. Yeah.
Hello, ma'am. Am I audible?
Yeah. Yes.
Hi, ma'am. Good evening, ma'am. Excellent presentation. Fantastic. Fantastic. Yes, ma'am. A couple of questions, ma'am. In gallbladder and cholangiocarcinomas, when you're using the hypofractionated RT, do you also use concurrent chemo
Gallbladder,
radiation?
I'm not using. I don't have the courage, because gallbladder, they are typically around duodenum. So you
Okay.
can't. So I don't practice hypofractionated or SBRT for gallbladder yet. But yes,
Okay, ma'am.
cholangio, flat skin, I'm going to cover in the next lecture. So if they are
Okay.
little away from the duodenum, and if they can breath hold technique, so
Yes,
then
ma'am.
I'm using SBRT for those cholangios, but not for others.
The 15 fraction SBRT or the 5 fraction SBRT? The
So
NRG-GI protocol or the?
Intrahepatic cholangios, there's a beautiful paper by MD Anderson that when your BED reaches, beyond 95 gray or beyond 90 gray, yeah, so then the overall survival is drastically better. So as long as you can safely deliver a very high BED dose, even
Okay,
flat
ma'am.
skin, like little in the upper segment, if it's away from the duodenum.
Okay, ma'am.
So when we started doing SBRT for these cases, so we did not use a breath hold, and our first 2 patients did develop duodenal ulcers, which was pretty scary.
Yes, ma'am.
After radioembolization and all, we managed them, but it is not a good idea to practice hypofractionation if you don't have breath hold technique in your center and 4D CT.
We have, ma'am. We do that. Yes, ma'am. Yes, ma'am.
Yeah.
So in those 15 fractions, you don't add concurrent capecitabine or any form of
Oh, you
cisplatin or
can
simple.
actually. If the volume is small, you can. You can. Why not?
Okay.
You can.
Okay.
Yeah.
Okay. Thank you, ma'am. Okay.
Hello.
Ma'am,
Hello.
Yeah. Yes, Rekha, tell me.
हेलो मैम मैम मेरा क्वेश्चन ये है कि इन गॉल ब्लैडर पोस्ट ऑफ सेटिंग इज देयर सिग्निफिकेंस ऑफ द एलबीएसआई
Yes, that is one of the poor prognostic markers. Nodal involvement as LVSI, then the liver, even in the gallbladder, which surface is involved, the liver surface or the peritoneal surface. So liver surface will have a direct invasion of the liver and more liver metastasis. So all these are prognostic markers. Yeah.
मैम मोस्ट ऑफ केसेस इन हिस्टोपैथोलॉजी देयर इज a T2 and 0 negative margins, only high risk feature is LBSI. So we should take patient upfront for post op radiation.
Yes, yes. So that's why we are including these cases in our randomized trial, where we are giving 4 cycles of capecitabine followed by CTRT, like the SWOG study.
So ma'am, if we conclude the post-op indication of the radiation in carcinoma gallbladder in adjuvant setting is T2, LBSA positive, T3, T4, node positive, and node margin positive.
Yes, all
Okay, thank
would be
you,
there,
ma'am.
but again, there is no comparison. There is no level 1 evidence comparing to the adjuvant chemo. So therefore, the medical oncologist can always argue that standard is chemotherapy, but there is a case. But there is, we can't say there is no evidence. There's lack of evidence, and the randomized trial is on the way. But yes, because because another argument is, I did not put up that slide because we are going, Dr. Shirley is writing up that paper, the TMH all T2 plus tumors, T2 and early T3 tumors, where they operated the pattern of recurrence. So pattern of recurrence is like 30% had local recurrence alone, and another 30% had local along with distant mets. So imagine in a solid tumor, 60% local recurrence is unacceptable. And we, as because and there was always in MDT the argument, and we could not never, because there was no trial, so we could not convince our surgeons. So they continued with and chemotherapy also. There were no strict indications. I mean, so some patients they gave chemotherapy, but majority they gave chemotherapy. So in spite of giving chemotherapy, imagine the local recurrence of 60% is actually unacceptable, and they die a very miserable death, these patients. So forget the distant mets, local recurrence, keeps blocking their stent. They have jaundice, they have vomiting, and they are very living miserably. So there is definitely a role of post-op chemoradiation in all these cases.
Ma'am, one more question, please. Is there any significance of the age beyond what age we can skip the post-op radiation?
Beyond what age?
Yes, ma'am. Like suppose patient is 76-year-old या फिर 80 and pathological T2 LBSI positive, rest high risk features are negative, then we should keep patient on observation, or we should give radiation post-op adjuvant.
So then you have to discuss in the MDT as well as discuss with the patient. See, now age is just a number now. A 60-year can also look like a 85. 80 years can behave like a 65. So you cannot take a unanimous decision like that. But yes, you have to discuss with the patient that these are your chances of local recurrence. These are your chances of this thing. You are this much old. So then I think it should be in the discussion with MDT along with the patient's wish.
Okay, ma'am.
Like that.
Okay,
So,
thank you so much, ma'am.
Yeah.
Okay, ma'am. Thank you, ma'am.
You can go slow with very old patients. Yes, I agree. Yeah.
Okay, ma'am.
Yeah.
Ma'am,
thank you, ma'am.
Can I ask you one question, if you allow me?
Yeah.
Hello.
Yeah. Tell me.
Yeah, ma'am, if you have a patient locally advanced CAGB, non-metastatic, so there are one scenario, the tumor is infiltrating duodenum and is going within the duodenal lumen, and the other scenario, the tumor is touching the duodenal wall but not infiltrating and going within the lumen. So
Yes.
will you consider both these two situations for a definitive CTRT, or will you customize between them?
Question. So when we come across such cases, so first endoscopy is a must to document how much is the infiltration. So if it's just touching from the outside wall and it is not infiltrating, you can't see the mucosa infiltrated in the duodenum, then yes, you can safely go ahead with CTRT. But if there's a frank infiltration, so there have been reports, few reports, there was a fistula, and surgeons always there's a fistula. But then there's Dr. Anil Agrawal in Delhi, I've attended many of his lectures and I talked to him. And he says, doesn't matter, even if it's a frank infiltration, he does something called sleeve resection. So see, duodenum is a nice, a thick tube, at least 2.5 inches thick tube. So that part which is infiltrated and has regressed, he removes that part of duodenum and stitches it back, because whereas the Japanese, they do the full on Whipple's resection. They remove the pancreas head also along with that full duodenum. So it's a different kind of philosophies. At TMH, Dr. Mahesh Goel doesn't prefer this. He says it's a very aggressive tumor and they are going to behave badly. So there's no point in, do such aggressive surgery for these tumors. So it's actually a surgeon's philosophy across the globe. But touching the, if there is no frank infiltration, I would not shy away from giving CTRT.
Thank you, ma'am. Ma'am, there is a question in the in the chat box. During
During
radiation
our
planning, should we keep in consideration of stent, whether stent causing any secondary radiation? So I think the
Yeah,
question should
that's
be,
another very, very good question. So see, so when when you're seeing in a MDT, so see there is see even locally advanced like pancreas also for gallbladder, like there can be a never ever situation where the tumor is infiltrating the common hepatic artery and right hepatic artery and extensive infiltration of the duodenum, and at that time like it is more like a palliative case, so then we put in a metal stent. But when because this patient is 99.9%, it's never going to undergo surgery, but we have seen in our previous study what we had published, whenever there was a metal stent and we gave neoadjuvant chemoradiation followed by surgery, there were high incidence of biliary leak. The CBD becomes very thin and it can leak. So we have to be careful. But when we expect that yes, patient can undergo surgery and there is there is chance of going out, it's a borderline resectable kind of gallbladder cancer, then definitely we don't ask for a metal stent. There's something called a plastic stent, which the shelf life is means like it has to be replaced frequently, but then there are lesser complications with a plastic stent than a metallic stent. So definitely we avoid metal stent when we expect the patient might go for surgery. Does that answer your question?
Yes, ma'am. Thank you, ma'am. Thank you, ma'am.
Yeah. Any more questions?
Yes, ma'am. Ma'am, what should be your inclusion criteria for considering patient for NACTRT in locally advanced CHB?
Yes. So we have in our Polka GB trial, we have all T3 tumors with a liver invasion of more than 1 centimeter. So these patients are like in the poor risk category. They are going to, the margins, even the wedge resection is going to be large. Then the second criteria is portal nodes, when they are portal nodes. So even if they appear small, portal nodes in an image, that when usually when the surgeons go inside, these are matted and stuck to the porta, and when they try to remove, there's always a R1 resection. So when there are portal nodes, this is the second criteria. Then partial encasement of the vessels less than 180 degree of the common hepatic or and this thing. Then there are portocaval nodes, presence of portocaval nodes, presence of this thing up to the retropancreatic nodes. So all these cases can be considered as locally advanced, because even if they undergo surgery, the outcomes are very poor and chances of R1 resection is higher.
Ma'am, what are those nodal stations should be considered while planning for a NACTRT? Your take on that?
Yeah.
Which
So
nodal station?
yeah. So what we do is the gross nodes. We try to give them 50-52 gray at least, and up to prophetic dose, you have to go up to level 16A, like that, and a retropancreatic region. And typically we also as a part of thesis, we saw the patterns of recurrence. So the gallbladder cancers, when they undergo R0 resection, the local recurrences are mainly, if it is not in the primary, the nodal recurrences are just below the pancreatic head on the left side of the duodenum. So right side of SMA and right side of celiac trunk, and left side of duodenum. So you get which area I'm talking about?
Yes, ma'am.
Yeah. So that area, that nodal, because it's very rich lymphatics, and that needs to be covered.
Okay, ma'am. Oh, ma'am, one more last question. It's a logistic question. So, for example, if we institute with only 3D CRT plan without any 4D CT simulation technique, planning for a CAGB case locally advanced. So should that patient be counseled to go for any other institute where the tomotherapy or SBRT is
No, you
is
can.
being conducted?
See, yeah,
Hello?
I don't think so. Only if they have to go for higher doses, then it's IMRT and with all this is recommended. Otherwise, a good 3D CRT, if you can control the doses of the duodenum, yes, it can be planned. So you have to arrange your beams accordingly, because not only gallbladder, restricting the doses to the right kidney and the liver, with an issue. So with 3D CRT, so then if the volumes are small, see, if the liver infiltration is like less than 3 or 4 centimeter, yes, if the volumes are smaller, then 3D CRT could be delivered. But if the volumes become large, there's large liver infiltration and all, so then I think IMRT would be beneficial. So you should weigh the pros and cons, where you can deliver 3D CRT safely with adequate portals.
Yes, ma'am. Thank you, ma'am. Thank you very much.
Yeah.
Good evening, ma'am. Hello.
Yes.
Good evening, ma'am. I'm Suranjan from Kolkata.
Yeah.
My question is, ma'am, if there is a patient with locally as well as GP cancer, and we are planning for upfront RT, rather for a NACTRT. So, is there any contraindication when the patient comes with only a raised bilirubin, and that is only for conjugated bilirubin, the proportion of the unconjugated is much less, and otherwise the LFT is absolutely fine.
What is raised? The bilirubin is raised. What's the background noise? Yeah.
Ma'am, could you listen to Dr. Suranjan's question properly? There is some noise, I guess.
So I don't want to give RT alone. It always has to be concurrent chemoradiation. And with gemcitabine, it's a very good radiosensitizer. So we have to wait for the bilirubin to drop to less than 3.
Okay, madam. I just wanted to know whether it is contraindicated even if it is, other LFT parts are normal. So it should not be given unless the conjugated bilirubin part is less than 3. Yeah, ma'am.
Yeah.
Okay.
Because chemotherapy can't be given. There's no correlation of bilirubin to radiotherapy, because it doesn't worsen. But because concurrent chemotherapy they will not be able to give. That's why.
Okay, ma'am. Understood. Thank you, ma'am.
Thank you, ma'am. And I think there is no more question.
Okay,
There
great.
is no question in the chat box also. It was a wonderful session, ma'am, and I think it's almost 1 hour and 40 minutes now you are taking this class.
Okay.
Thank you so much, ma'am. It's an exhaustive task for you. And we are meeting again on Wednesday, ma'am, at 8 p.m. for the next session on hepatobiliary. So the next class will be on cholangio and liver.
Yeah. Okay.
Thank you
Thank
very
you so much, ma'am.
Thank you.
Bye.
Good night, ma'am. Good night.